Okay, the story of this is a 5-year-old child who has got a perimembranous bar high muscular ventricular septal defect, which is measuring around 6 millimeters. The VSD is rather significant hemodynamically. The Z-score of the left ventricular dimensions was 3.5. Now, doctor, can you show me a live echo? We don't have time for a PowerPoint. Just go to live echo. Live echo from this lab. Not that lab, this lab, second lab. Okay. So this is the.
Okay, flush everything.
Can you collimate now?
Pramod,
take your hands out. I will first collimate and get the.
This is a venous sheath.
Now collimate sharp. Collimate sharp. Don't allow the apex to be seen. I want an apical echo. Collimate. Collimate. Further and further collimate. Close it. Okay. Not so much.
Now you can't see anything.
Now zoom it now. Okay, so now a little bit open it. Okay, now what I'm going to do is I'm going to come out, show hemodynamic monitor. Wait, hemodynamic monitor and Pramod left after some time. So open this one, open the collimation. Hemodynamic monitor plus fluoroscopy live plus hemodynamic monitor plus angiogram live. Yeah, correct. So now I am actually pulling back my catheter. I am trying to engage the left ventricle. Now I have fallen into the right ventricle.
How much is it? 1 hour. Hold on.
I am slowly dragging my catheter in order to cannulate the left ventricle. Go to cranial projection also here, so that I get a little better orientation. That's enough. Little bit more. That's enough. Okay, I came into the RA. One more try.
Shiva, they're asking in the audience, are you using a biplane?
Sorry, no.
A biplane lab?
No. It's a single plane. Come to AP.
But Shiva would like to say, if anybody would like to donate a biplane lab, he'd be very keen to accept it.
Yeah. Okay, that's fine. Okay, again put back on hemodynamic monitor. Wait. In this view itself, I'll try to come. Get the Cordis RCA ready. Cordis RCA already we have taken. Cordis RCA. Yeah. What is that?
Alan, you're an exponent of this approach. What's your advice? We've got a right coronary. I'm going to start cutting the tip off a pigtail, or
go inside.
Use something else. Alan, Dr. Fritz.
I always cross it from the LE side, but yes, usually it is relatively simple from the LE side. From the RV side, I have less experience. Usually I go with the right junction, just like if I would like to go to the pulmonary artery, and I slowly come down and try to cross it by pushing directly with the catheter.
For us old people, Shaq and I remember catheters called Cobra catheters. Remember those, Shaq?
Okay, did you
Absolutely, they're still available.
Okay, this is I have crossed it. Did you see that I have gone into the left ventricle? Okay, now go to LAO view.
Who needs Cobra catheters?
Okay, now I want a guide catheter. 5 guide. Okay, now I am actually advancing my wire into the right ventricle, and I'll try to get it into the aorta. Okay, now guide 5. Left ventricle. 5 guide, bro. 5 guide.
Just take your time, Siva. If we miss it, we miss it. But
Yeah.
I don't want you jeopardizing the
Okay.
patient.
Okay, okay. Shaq, just extend by 1 or 2 minutes. I'll complete it.
Siva, we know Chennai minutes last
Yeah.
quite a bit longer than normal minutes.
Normal.
As a child, I will fight Shaq. Actually, Aklutech AFR, the previous case, they marched into 3 minutes of my time. So,
Okay.
All right. We'll give you 2 more minutes extra.
okay, yeah.
So you've got 6 minutes now.
It's probably up to Inga. Inga makes those decisions.
No, we'll tell Inga.
Inga, where are you?
Okay. Keep advancing
Inga,
slowly, slowly,
I'm
slowly.
here.
do we have
You
permission
can
to?
have a couple more minutes. It's okay.
Yeah.
Danke.
1 second, 1 second.
No. No.
Okay, slightly.
No. I don't know what length is the wire you have?
It's a full exchange length, but then
Okay, good. So if you could get that down to the descending aorta,
Yep.
and right down one of the femoral
and pinch it
arteries,
and pinch it.
you can
Yeah.
press on the femoral artery and
Show the top.
try and use it as a rail almost. Yeah, perhaps not do the carotid.
Well, you can ask the anaesthetist to press then.
Oh, there we go.
Come to AP view.
It's
AP.
incredible, isn't it?
AP
If you
view.
were trying to get up the
AP view.
right
Show
common
the,
carotid, you know, it would prove impossible, wouldn't it?
it's not. Okay, show me the heart. Let me.
Yeah, you might have enough wire now or not. Yeah, there
well
you go.
done.
Yeah.
Well done.
Okay,
The
ADO
anaesthetist was
264.
secretly pressing the wire.
ADO 262, 64. Show me the LV. Get me the ADO2 cable also opened. Show the heart fully. The heart is partially not seen, the LV lateral bottom. Yeah, give the delivery cable.
So this, just remind us, the guide catheter is what, 5 French? or-
Yeah, it's a 5 French Medtronic launcher guide catheter.
Yeah. Yeah.
And I am taking the ADO2 delivery system. Okay, open the device, ma.
Which device are you using?
I am using a 6-4 ADO 2 device, which has got a 6 millimeter diameter waist, 12 millimeter 2 discs on either side. Give me some light here.
Yeah, I hate that device.
Siva,
Yeah, Tin.
can you tell us any information about the morphology of the defect?
Okay.
on
Now show the echo. Show the echo. Sorry, Tin. Actually, the time was running short, so I cut off some of the echo pictures. It was a perimembranous with, but there was a separation from the aortic valve. Okay. Keep fixed on the picture. Now see the. I'll try to do it without fluoro with. Pramod, once can I go to the tip of the sheath and then you give me the same picture?
So show us your hands and fluoro in the meantime.
He has taken
Yes,
it
and
out.
just-
Neil will not allow that.
Shiva, just be conscious of the tip of your
In the papillary muscle.
delivery catheter in the myocardium, because those
Yeah, I have
those
pulled out.
catheters are quite stiff, and
I have come freely inside. Okay, now you show me, Pramod. Okay. So now I have deployed the one disc.
Can we see the echo now?
Yeah, echo big, echo big, echo big.
Yeah.
Very nice.
Okay, now I want to release the second disc also. Pramod, hands out.
Just be conscious of the appearance of the mitral valve leaflets.
Yeah, mitral valve I have come out, Neil. Okay,
Sure.
now show the, I have come out into the LVOT now. Show the
So
device.
you've opened both the discs in
no,
the LV.
Two
is that
discs,
right?
the central belly also in the LV.
Yeah.
Yeah, so now I am going to pull back and hug the, okay,
Keep showing that.
I'm going to hug the,
At the moment, Shiva, you're purely doing echo, not
yeah,
fluoro. Yeah.
no fluoro, no
Can we-
fluoro, no
Can
fluoro.
we do echo big then?
Echo big,
Nice. Thank you.
consistently show the picture. Okay, I have touched the device, now hands out, echo out. Now fluoro, now fluoro.
All right, let's see fluoro big. Yeah.
Okay, now again echo. Okay, first AR.
It's okay there, doesn't it?
Yeah, aortic valve is okay. Probably on the right side, my hand will be better to do an echo. Get another pair of glove.
Nice.
There,
Zoom
that's
that
a
area.
nice view.
Zoom that area. Yeah. Yeah. So we nowadays we do without arterial access, only with venous access. We do these VSDs. There is some amount of flow, but I feel that it is this is a non-fabric device, so it should take a little bit time. I will show you a parasternal short axis.
And then you've got about 1 minute.
Yeah, yeah.
to
I will release it and give you a PA angiogram lever phase.
Siva,
Okay, color.
main problem is in the IDO 2 is the tricuspid valve regurgitation, and you should check the TR, any TR.
Okay, tricuspid regurgitation. I have the guide catheter now across.
moment.
Yeah, I will remove it and then I will show you tin.
Yeah.
Get me a new pair of
Oh,
gloves.
yeah.
Release it, Ashish.
No, yeah.
Ashish, under fluoro release. Fluoro and then release. Get me yeah, keep a J wire ready, sister. We are exchanging it into a pigtail. Yeah, release it now. Super. Okay. Now, sister, get me one. Set an injection for a PA angiogram lever phase.
Oh, this is
So
not.
no rush, but you've got 1 minute.
Come
Shiva?
to AP. Yeah,
Shiva?
yeah, Dietmar.
Nice job. Nice job.
Oh, is that?
It's Neil.
Okay,
I
okay.
think we've seen enough. In the interest of time, I think we should let you go there. Shiva, what?
Yep. Yeah, yeah.
Excuse me asking.
Yeah.
As Jacob,
1 second. It is being a rigid guide catheter. I'm fine taking time. Tell me, Neil. I didn't hear you fully.
as Jacob,
Jacob. Oh, okay. You are asking about the secretary Jacob, who was the head of the organization.
no,
Ah,
no,
okay. Jacob is a surgeon.
yeah, no. We'll talk again another time.
Okay, okay.
Which Jacob do you want to ask about? There's probably 10 of them.
I'm not sure now anymore.
All right.
We will get you once again to MMM and have a Neil Wilson.
Right. Shiva,
No, okay.
30 seconds.
Pigtail. Get the
Shiva,
pigtail.
30 seconds.
Yeah. Get the injector ready.
So you're going to do a PA angio and follow it through, are you?
Yeah, yeah.
That's it?
Shaq is more cruel than Inga.
Well, we're 5 minutes into Horst's case now.
Oh, sorry.
And
Sorry.
somebody-
I feel sorry about it. Yeah, I know that.
You sound very, very sorry.
Alan Press is proposing a debate at CSI between him and you, Siva, about venous antegrade versus arterial retrograde for perimembranous closure.
Actually,
And he's already volunteered.
okay.
In fact, he's volunteered both of you, so there you go.
We have totally, we are now totally into transvenous alone. We don't do arterial. Most of the cases we don't take an arterial access at all, but in this particular patient we have taken one small cannula for an arterial pressure monitoring, which we normally don't do also. Because this is a live transmission, we just wanted a continuous monitor of the hemodynamic stability, so we have done it.
Shiva, you're sorting out a debate already. So
Yellow cranial, 45-30. What is the weight of this child?
stop talking.
20
is
20 ml 15
poised.
rate.
Inga is poised like a coiled spring to react.
Yeah, little bit more. 20 at 15. Ready? Shoot.
Oh, I don't like that expression,
Yeah, I don't either.
particularly when you've worked in America.
Look at that. Yep, brilliant.
At
Shiva,
last from Germany.
superb case, superb demonstration. Thank you. Thank you very much.
Okay. Keep running. Thank
So
you.
thanks so much.
Thank you.
Thanks so much to your team for the transmissions today. They were really great cases. But now we do have to move back to CDC Frankfurt. Dr. Sievert is